Here we go.
Okay. Good morning, everybody, and thanks very much to the Butte-Glenn Medical Society and the Anlo Medical Center for this opportunity to talk to you, with you about the COVID-19 pandemic and the essential roles that healthcare providers play in the prevention, the surveillance, investigation, contact, care of individuals in regard to transmission of the SARS-CoV-2 virus and the COVID-19 disease. The outline for my presentation today is on the screen. This is a global pandemic. How is the US doing? What credible forecasts are there for cases and deaths? What's it look like in the absence of a vaccine that may or may not be available to the public at large until the middle of next year? What's the epidemiology for cases and deaths in California and Butte County in particular? What's Butte County's COVID-19 status in the California blueprint for a safer economy? What are the essential roles for healthcare providers in prevention and control of COVID-19 and working with the county health department and other stakeholders? And then what are some current issues in particular in regard to point of care testing and reinfection? There are three principal learning objectives. I would like to help update your knowledge about the epidemiology and the impact of COVID-19, as well as the important roles that healthcare providers of all kinds can play, laboratorians, physicians, nurses, and so forth. Increase the attendees' knowledge and access to CDPH and CDC guidelines, and strengthen the intentions and abilities of yourselves to follow those recommendations. I'm going to include some cartoons as I go along, and I by no means am doing that to belittle the magnitude and severity and importance of this problem. It's a global pandemic. How are we doing? Well, the answer to that, unfortunately, as outlined in the red boxes, is not very good. In fact, it looks like we're doing the worst of developed countries in the world. There have been more than 47 million COVID-19 cases reported to the World Health Organization. Many countries and cities in those countries have successfully prevented or controlled transmission with comprehensive evidence-based approaches led by national and local leaders. We don't always have that guidance in the US. And interestingly, for the first time, most of the world's countries have rallied behind plans to accelerate the development of vaccines, diagnostics, and therapeutics which are needed, and to ensure that they're available to all countries on the basis of equity. Two WHO coordinated programs are mentioned in this slide, and I welcome you to have a look at the internet websites to see what those are about. So we've not rounded the curve. That's pretty clear. These charts from the Washington Post are based on data from the Centers for Disease Control, from the county health departments across the country. It's clear that both in terms of cases reported in the last week, as well as deaths reported in the last week, that things are not going very well across the country, and in some areas in particular. In California, thanks to the governor's efforts and the efforts of local health departments like ours, we seem to be doing better than in some areas. But we're in for a bad time. And that's pretty clear from the trends that you can see in this slide here. The new daily cases reported increased by 16% in the last week. The new daily deaths reported by almost 14% in the last week. And for provider-based or working with hospitals, COVID-related hospitalizations rose by almost 13% in the last week. Not good news. What do credible forecasts epidemiological statistical forecasts for cases and deaths look like in the absence of a vaccine. The Institute for Health Metrics and Evaluation model, which is often referred to by the White House's COVID-19 task force, and which is collaborated with WHO in the Global Burden of Disease studies, has done very well compared to 7 or 8 other agencies which have engaged in statistical modeling. And when I say very well, what I mean is that the median absolute percent error that they have had in their forecasting efforts has been less than 20% for cumulative deaths compared to subsequently observed trends for weekly and cumulative death forecasts. And the way that they have engaged in this is to present their results under 5 scenarios. The 5 scenarios are, number 1, as you can see in this expression of their modeling work, with mandate easing, which would be disastrous in terms of the health and safety of US residents, but also in terms of the surges that would occur in facilities and hospitals. Number 2, mandate easing with a universal recommendation for mask use. Sorry. Thirdly, plausible reference, which they use, which would include um, um, some mandates on social distancing or physical distancing. Fourthly, a plausible reference, that same plausible reference, but added 85% mask use. And finally, universal mask use. But it has to be said that the US is likely to face a continued public health challenge from COVID-19 through February of 2021, or until we have a safe and effective vaccine accessible to all people. With populous states in particular potentially facing very high levels of illnesses, deaths, and intensive care unit demands as a result of the disease. And you can check out the links that I've provided on this slide to look at that in further detail. So just another expression of these same data. In this case, looking at the daily infection rate. This is the first slide I showed was daily deaths. This second slide is estimated infection rates. And finally, estimated intensive care unit beds if these recommended scenarios don't take place. These are the ones that Dr. Fauci and Dr. Redfield have referred to when they've been given the opportunity to have press conferences. So what's the epidemiology for cases and deaths in the USA, in California, and in Butte County? And as you can see here, we're in trouble. We're going to be coming now into the flu season, the occurrence and distribution of cases, infections, cases of influenza, as well as infections and cases of COVID-19 are going to be occurring together. These are the case numbers to date for COVID-19, and we appear to be in a third surge of cases based on the 7-day rolling average as of the end of October. So this is what the situation looks like, and in particular across rural America. The red non-metro counties that are lighted up in this illustration as of the week of October 17 to 23. You can see that in terms of the number of cases per 100,000 residents in the rural areas in red, that the situation is not good. In the non-metro areas and the metro areas, the situation is also not good. So as of the 3rd of November this week, this is the number of cases that have occurred across the state of California, and the fatalities across the state of California, and about almost 1 million cases, nearly 18,000 fatalities. Bad news. If we look at the data across the California state in terms of ethnicity, and let me see if I can bring up my pointer. My pen order. So in terms of, oh, come on. In terms of, I'm sorry, don't seem to be able to get the pen to come up. See if I can do that now, okay. If we look at Butte County, the distribution by ethnicity of the number of deaths in Butte County, certainly to some extent, reflects the distribution and occurrence of infections and cases, but is further modified by access to care and availability of care to different ethnic groups in the county. But across the state, there are certainly differences. They may represent disparities rather than just differences in terms of access to care, availability of care, ability to afford care, and the kind of care that people are able to access across the state and across the county. If we look at gender, there's not a large number of difference in cases, but there does appear to be some difference in terms of deaths. Not sure what the reasons for that are, but I don't have the difference illustrated in this slide for Butte County, but this is the difference across the state. And in terms of age, again, some differences that may represent disparities in terms of the cases and the deaths by age. And I'm not illustrating those same differences in Butte County. Our numbers are small, so to put them in terms of rates would be difficult. And the only way to compare them across the state and the county would be to have valid rates to compare. For Butte, for Butte County, our total cases as of this past week were more than 3,000 positive cases and 54 total deaths. This slide compares with the blue line in cases, the situation in Butte County and the situation across the state, and it's expressed as rates. So you can see that we had a peak here about the time that university and college students returned to Butte County in cases. And we've had several peaks that may reflect gathering related events and changes in the demography in the county over time, over this past couple of months. But the point here is that Butte County has by no means been immune from the kinds of problems that have been occurring across the world, the county and the state. This illustrates the impact on hospitals in Butte County. While the numbers are not large here in Butte County at the moment, if the surge that appears to be coming towards us, tsunami-like surge that may be coming towards us in the next weeks and months, that situation may very well change in terms of the hospitalized Butte County patients and the ICU hospitalized Butte County patients. In terms of testing for COVID, um, in comparison to the rate of testing going on across the state, um, we are tracking along with the state. We've had some increases in testing about the time that we had the increases in current cases occurring, and public attention to the need for testing may have increased that. And we've had some changes in the test rates as well. It's really important for the testing to go on, and the role of providers is critical in that, as I'll talk about in the next couple of slides. So what's Butte County's status in what's referred to as California's blueprint for a safer, and I should say safer and healthier economy? Um, the, um, the state has used a system of tiers, 4 tiers, representing widespread transmission, risk of transmission, substantial risk of transmission, moderate risk of transmission, and minimal risk of transmission. And the way those tiers are assigned is based on 3 considerations. One consideration is the adjusted case rate, the 7-day average cases per 100,000 in the previous 7 days. The positivity rate when testing has taken place for the 7-day average, and an effort to assess and address health equity, socioeconomic characteristics of the county in terms of access to testing and use of testing. And given those 3 criteria, the state on a weekly basis assigns a tier level to counties. At the present time this week and for the past couple of weeks, and still for the next week, hopefully in a couple of weeks, perhaps longer, or maybe we'll even get to minimal. But at the present time, we're in what's considered the moderate county-wide risk of transmission for COVID-19, for SARS-CoV-2 virus and COVID-19 disease. You can take a look at the website that I provided there if you want to examine the criteria and how that's done in more detail. So here's a picture of where we are in the state compared to other counties in terms of these 4 tiers of risk of transmission. We're orange, we're in the 3rd level, nearest to the lowest level for transmission. What's that mean in terms of reopening our economy in Butte County? I've given some examples here of the kinds of activities or settings in which our moderate risk of transmission tier places us in the county. And you can take a look at this. You can look on the website to see other examples of activities and where our moderate level of risk of transmission places us in terms of the advice the state provides for whether those activities can take place and under what circumstances they can take place. Now let's get more towards the questions of what roles providers can play and the immense importance those roles have in preventing and controlling the transmission of the virus and the onset and occurrence of the disease in Butte County. Dr. Tom Frieden, one of my heroes, a previous director of CDC, has described this process as boxing it in. The testing of individuals, whether they're asymptomatic or symptomatic, depending on the circumstances of engaging in screening or surveillance or diagnostic testing. But in one way or another, a test needs to be given, and on the basis of that test, whether it's a PCR test or the more frequently the frequently being applied antigen tests, and we'll talk about that a little bit longer later on. The results of that test gives the infection status of an individual who may be infected and therefore needs to be isolated with guidance from a provider and the county working together on what isolation consists of, what the criteria for isolation, the length of time of isolation, um, and then in working with the county to identify contacts, close contacts of that individual who's infected, to find individuals who need to be advised to quarantine themselves for a period of time, and the circumstances for and the duration of that quarantine, which is not an easy process and may require guidance from providers as well as the county working together uh, in terms of how to successfully interrupt disease transmission. But as you can see in this illustration of the importance of contact tracing, if we're able to properly and adequately identify cases and their close contacts, we can have an enormous impact on the spread of the virus and the occurrence and distribution of disease in the county, as illustrated in this slide. And again, injecting a little humor into the presentation. A key role for providers is working together with the public at large, your patients, your clients, and with the county to prevent and control the spread of COVID-19. In this um, uh, cartoon here, a passenger on an airline is sitting next to an individual who's got 6 arms. And the person with 6 arms is telling the passenger, "Oh, is this your first trip to Indonesia? This will be my first time back to Indonesia since the spider bite." A psychiatrist says, "If I don't face my fears, I'll never conquer them." Well, despite the effort at humor there are some important roles for providers in being vigilant, to undertake testing and to proceed with the isolation and quarantine work that needs to be done in collaboration with county officials following the results of that testing. One of the really important roles for providers is to participate in the myth busting work that has been described by WHO and by CDPH and by the Centers for Disease Control and the county in terms of addressing the large number of misinformation and disinformation that is accessible and unfortunately and used unfortunately by a large number of members of the public. And unfortunately by some of our top leaders um, in terms of the nature of COVID-19, the magnitude and severity of the disease, and the ways in which it's important to prevent transmission of the disease. So please have a look at the links that are mentioned on this slide. The slides are available from Christy at the Butte-Glenn County Medical Society, and I'm certainly happy to distribute them myself as well. My email address is on the first slide of the presentation. But this is an enormously important role that providers have, because you're the trusted persons to whom individuals come when they have heard these myths, and what you can do to help change their behavior is critically important. There are posters that are available from the Centers for Disease Control, CDPH, that you could put in your practice, in your office, in the emergency department, at the Enloe and other hospitals in the county. And of course, you can vote or have voted, I hope, effectively to emphasize the importance of non-pharmaceutical interventions, which unfortunately have been disparaged by some of our political leaders. But it's critically important that the correct evidence-based, peer-reviewed information is available to the public, and providers are the first line of um, opportunity to provide that information. There's been some concern about whether masks, surgical masks, the cloth masks and so forth are effective. There are issues in the effectiveness of masks, but for healthcare providers, there's been a number, I have a library of 20 or more peer-reviewed examples of the effectiveness of masks. This is just one that was published in JAMA as a research letter concerning a study that was done at the Massachusetts General Brigham and illustrated the importance of implementing a masking practice among providers in that healthcare setting. Another really important message to get out, especially now in the season, is to have providers and the public get their flu vaccines. And it's just so important. So I'm going to talk for a couple of minutes now about a couple of issues that have come up for which questions have been raised on the point of care use of antigen testing. This is a protocol that the County of Monterey has implemented in terms of how to interpret the results and take action based on the results of the use of antigen tests. I'm sure that most providers in the county have informed themselves already about the difference between the technology involved in the use of an antigen test for some of the proteins on the surface of the SARS-CoV-2 virus, contrasted with the PCR test, nucleic acid test, for the contents of the virus. And the sensitivity and specificity of those two different types of tests, and the populations in terms of the pre-test probability that an individual being tested would be likely to have been infected, have been exposed or infected based on the symptomatology of that individual, or whether that's a close contact of a case, or other circumstances for the application of the test. But there are differences in the interpretation that one can apply to the use of the antigen testing on the surface of the virus and the nucleic acid testing of the nucleic acid contents of the virus. This slide illustrates some of the decision making that has been recommended in the County of Monterey, and that we're adopting as well in Butte County with regard to the application of this test in skilled nursing facilities and long-term care facilities and other clinical settings. And I would encourage you to have a look at this slide and think about how best to make use of antigen tests in your practice. This summary provided by CDC in this slide characterizes the different testing strategies, whether they're in diagnostic settings, screening settings, or surveillance settings, um, and the results that might be obtained under those different settings. The Butte County testing sites are at a website that's listed here on this slide. And there are a number of those sites available in Butte County. And the CDC testing guidance is also indicated here in the link. Currently, there is no identified performance advantage of using antibody testing assays, regardless of whether they test for the IgG, IgM, or IgG, or total antibody response to an infection with SARS-CoV-2 or a person with COVID-19 disease based on a positive antigen or PCR test. And that's a really important thing for providers to keep in mind, that antibody testing is really not part of the diagnostic workup at this time. Certainly antibody testing is going to be important from a population point of view and a clinical provider point of view when vaccines become available, safe and effective vaccines become available to track and follow the protection provided by such vaccines. But at the present time, there is no identified performance advantage diagnostically or for screening by the use of antibodies. What about return to work criteria for healthcare providers who have had a positive SARS-CoV-2 diagnostic test? The symptom-based strategy to determine when a healthcare provider can return to work is illustrated on this slide. And the distinction here is made between healthcare providers who had a mild to moderate illness and who are not severely immunocompromised, compared to a healthcare provider who had a severe or critical illness or who are severely immunocompromised. So I'll just go through this slide, but I would encourage providers to review this information. It's available at the link that I provided on the basis of a August 10th CDC website guidance that was issued. For the first category, for healthcare providers who had a mild to moderate illness and are not severely immunocompromised, at least 10 days have passed since symptoms first appeared, and at least 24 hours have passed since the last fever without the use of a fever-reducing medication, and symptoms have improved. In those circumstances, such a healthcare provider could return to work. If the healthcare provider was not severely immunocompromised and was asymptomatic throughout their infection, they could return to work when at least 10 days have passed since the last date of their first positive viral diagnostic test. There's different circumstance for a healthcare provider with who experience a severe to critical illness or has a severely immunocompromised situation. In those situations, at least 10 days and up to 20 days should have passed since their symptoms first appeared, should have passed since their last fever without the use of fever-reducing medications, and symptoms, cough, shortness of breath, and so forth, have improved. And there should be a consideration of a consultation by the provider with infection control experts before um, allowing that healthcare provider to return to work. So I encourage you to have a look at the CDC website. Um, that's the link of which is provided here. What about reinfection with the SARS-CoV-2 virus? The evidence is certainly accumulating that reinfection is possible. A genetic, an epidemiological, clinical, serological, and genomic analysis was applied in one case that's illustrated on this slide, and the link to the article in which this case was investigated is provided on the slide. Um, the investigators in this case found that the SARS-CoV-2 infection may continue to circulate among humans despite um, the herd immunity that we're hoping for that'll occur due to uh, either natural infection or vaccine-induced immunity. Um, I think I'll say something about the false um, concept of herd immunity, natural herd immunity, that some of our, unfortunately, leaders, federal leaders have referred to, not the CDC, of course, and not NIH, but some other political leaders have referred to, which is definitely not an advice that CDPH or Butte County would advise following. The false claim that was followed, unfortunately, in Sweden for a while, that allowing natural herd immunity to take place by ignoring all the non-pharmaceutical interventions and allowing younger people to get ill um, in order to encourage natural herd immunity in the population at large is simply a false hypothesis that's been um, contradicted by hundreds of experts, infectious disease and public health experts across the country. But anyway, the point of this slide is that reinfection with the SARS-CoV-2 virus is certainly possible. The advice that has been issued by the Centers for Disease Control as of the 3rd of November with regard to patients who have a persistent or recurrent positive test for the SARS-CoV-2 virus is illustrated in this slide. Published case reports, like the one I just referred to, have definitely shown that reinfection is possible. But what's not clear is how long people who've recovered from COVID-19 are protected against reinfection with the virus, what concentration of antibodies is needed to confer protection, and how often reinfection may occur with a replication competent virus. And that's a key point, because the PCR test, as I mentioned earlier, is a test that very sensitively and very specifically identifies nucleic acid components of the virus, but not necessarily a replication competent virus. So while viral RNA shedding declines with resolution of symptoms, RNA shedding of the SARS-CoV-2 virus may continue for days to weeks. And that means that detection of the viral DNA by PCR, reverse transcriptase PCR, detection of that RNA during convalescence does not necessarily indicate replication competent virus infectiousness or the presence of new infectious virus. have a look at the CDC guidelines that are the links for which are 5 different links are in this slide, so that you can guide yourself on what CDC has come up with in terms of clinical management of patients with confirmed COVID-19 disease and or suspected SARS-CoV-2 reinfection. That advice is as of the 3rd of November. That's the end of my slideshow. Okay. And am I coming back to Christy?
Sure. So thank you so much, Dr. Bernstein. That was really well done. And we have been recording this, so it will be posted on the Butte-Glenn Medical Society YouTube channel. Was there anything you wanted to add? Or for me, I think you covered what I had a question on, which was, how to best prepare for the upcoming holidays with so many people wanting to naturally get together with their families. And but I think you covered that.
Yep, I think the flu vaccination is a key point. Don't fail to guide your patients around the mis and disinformation on masks and non-pharmaceutical interventions in the absence of a vaccine. Don't listen to false information about herd immunity protecting the population before we get access to a safe and effective vaccine. And the critical role that providers, and that includes not just the physicians, but the nurses and laboratorians and others in terms of the good guidance, the non-pharmaceutical intervention guidance.
Well, thank you so much. And if there's nothing
let me ask you a question. We had some back and forth with, gosh, what's her name at Enloe? Dory, is it? Dora?
Dora, yes.
About how the YouTube now might be made available to non-physician providers and the CME available to them as well. How are you going to advertise the presentation?
So once I get it posted to YouTube, I can then share the link. It's much easier to share a link to YouTube than it is to actually try to post a large file. That's the beauty of YouTube. And I need to be very clear, there's no CME from anybody who's watching this through YouTube or any of the links that we share. The CME is for the virtual grand rounds when they are held and people are participating, and I can actually see that somebody's logged in. I don't have that capacity.
Okay, that's interesting.
Yeah. But it's still very, very important to share these. I think we're planning to do a virtual grand rounds with you in January, and that would be for continuing medical education.
Yeah. Okay, great. Actually, if you have some thoughts about keeping that within 45 minutes or so, and yet dividing the participation by